organizing, putting together. It's not easy. Actually, I'm very happy to talk about this topic, especially at a time when I heard that the CPET device has arrived in Kandy, and there is enthusiasm among sports physicians, pulmonologists, and other allied healthcare staff to get this started. What I will do is cardiopulmonary exercise testing is a different subject in itself. It is a topic that we don't learn when we are in medical school, and nor is it in the routine curriculum. So it's a different topic. So I will give an overview, and if there is any input that is needed in the future, we will be happy to support, especially in Colombo. Well, few people do cardiopulmonary exercise testing. In pulmonology, it's myself and Dr. Dilesha Wadasinghe. We do CPET. So before I begin the talk, I would like to say that if I will be happy to. So it's not easy in the beginning. You will understand because there's a lot of facts involved. The test itself takes some time, at least half an hour to perform. You need a dedicated physiotherapist to be at the site. There has to be so it's a dedicated time, and then it takes time for the interpretation as well. So cardiopulmonary exercise testing, as the word says, it evaluates the heart, it evaluates the lung, it evaluates the metabolic system and the muscles. So it is one test that actually gives you an overall view whether your body is functioning. And now we do a lot of tests at rest. So a lot of tests that assess the systems of the cardiovascular or metabolic or muscular systems are assessed at rest. But if you put your body into exercise, it stresses, or it tests your physiology, it tests your capacity, your endurance, and if there is anything abnormal, then it will show as differences in parameters in a cardiopulmonary exercise test. So it's a dynamic, non-invasive test. When it says non-invasive because we're not going to do any investigation. However, you can do a cardiopulmonary exercise test, and during that, in some countries, in some centers, an endoscopy is inserted to see the function of the vocal cords during a CPET. So it can be at a higher level. But what we do here is the basic cardiopulmonary exercise test, where you get a patient to ride a bicycle, and I'll show you the pictures. So you get the patient to ride a bicycle, and while riding the bicycle, the resistance gradually increases. Now, those of you who know how to ride, who has done exercise on a treadmill, you can increase the resistance gradually. So like that, we increase the resistance gradually. And while doing the exercise, the patient wears a mask, and oxygen, carbon dioxide, blood pressure, ECG, breathing, tidal volume are continuously monitored. So all parameters can be seen. I'll show you. So usually people complain that they are breathless when they're doing something, when they are climbing a flight of stairs, when they are lifting something, rather than at rest. So it makes sense to make the measurements during exercise rather than relying on investigations performed at rest. So first I will just give you a brief case, and then I'll tell you the play, and then we will move on to the CPET, theory of the CPET, and then at the end we will interpret this case. So it's a real case. It's a 44-year-old female who was previously healthy, a teacher, who had mild COVID infection in 2021 August. Apart from that, she had been all right, and she was referred to us to evaluate persistent difficulty in breathing. Now, what she mentioned was she was always short of breath. She was short of breath when she was talking, when she was teaching in class. She felt as if there is not enough breath in the chest. She was breathing from the mouth more often than usual. Intermittently, she was taking large sighing breaths. She had excessive fatigue, and she felt something in the throat. Now, when this complaint comes, she also brings a huge pile of investigations where her chest X-ray had been normal, her CT chest has been normal, the ECG, the 2D echo had been normal, Holter monitoring had been normal. She had even undergone a tilt testing that was normal. A CT angiogram had been normal. The D-dimer has been normal. The spirometry, the lung functions are normal. She had a 6-minute walk test that was normal. So what is going on? What is going on in this patient? He has just done all the investigation, seen by multiple doctors. Now still she is breathless, and there's no explanation, and she's worried. So one of the screening or one of the clinical assessment tools that you do when you have breathlessness is the breathing pattern assessment tool. That is actually when the patient is talking to you, you observe the patient's pattern of breathing, and this patient had a lot of upper muscles used for breathing, the apical muscles, the muscles that that you see when someone is walking or running, apical breathing. And then you also hear whether the breathing is noisy, whether there's wheezing or there's noisy breathing, but this patient had silent inspiration and expiration. You observe whether the patient is breathing from the nose or the mouth or a combination, whether it is predominant mouth breathing, and whether there are episodes of air hunger. Air hunger is where the patient suddenly goes and takes a large breath from time to time. So this kind of observation gives you an assessment, and if the breathing pattern assessment tool is more than 4, that indicates that you have to go and look whether there is you have to assess for a cause for the breathlessness. So what I will do is, with this case in mind, let's look at the 9 panel plots, the flow volume loops, and I will go through the basics of the theory, and I will give a few more cases as well. So this is the cardiopulmonary exercise test machine on that image. I suppose you would have seen by now. So you have the cycle ergometer, we call it. You can have the cycle ergometer. You can have the treadmill where you do the exercise ECG for CVS assessment, or athletes who do the assessment, they sometimes bring their own ergometers, like rowers, oarsmen, they bring their rowing ergometer and they do their assessment. We commonly do on the cycle. So they sit on the bicycle and the resistance gradually increases. They have a mask where every breath is analyzed for oxygen, carbon dioxide, tidal breathing. Their pulse oximeter saturation, the blood pressure, heart rate is continuously monitored, and it will be displayed on the metabolic cart. The 2 TV screens on either side is the metabolic cart, which continuously show the patient's ECG, as well as the 9 panel plots I will show in the next slide. So we do a resting spirometry or a resting lung function loop, and we see whether there is an abnormality. And then we also do one again at the end of the test. So the patient sits on the cycle with a 2-minute rest period, and then we ask the patient to ride the bicycle for a 2-minute freewheel pedaling, and then we start the resistance to increase. We call it ramping up. So then they cycle against the resistance, and they have to exercise to the fullest. So we advise the patient to go to the maximum and not stop halfway. So you will need a clinician, you will need a medical doctor on site, and also the physiotherapist. So they will have to continuously reassure the patient, don't worry, you exercise, your parameters are good, but you also have to keep an eye on the ECG saturation and the oxygen pulse curves. If there are anything abnormal developing, even before the patient develops symptoms, they have to stop. I'll show you the graphs. So once you go to the maximum and the patient can't go any longer, the test is terminated, but you don't stop at once. The resistance is stopped, but the patient has to cycle until the heart rate drops. So there is a recovery period of 3 minutes, because it's important. Now you have been asked, the patient has been exercising for a good 5 to 7 minutes, and if you suddenly stop, the venous pooling can reduce the blood pressure. So even after stopping, even after reaching the peak exercise, you remove the resistance, that the patient has to continue cycling for a few minutes. So this is the 9 panel plot. It's called the Wasserman plot. Wasserman is the physiologist who actually described it, and this initial interpretation is from him. So these are the 9 panel Wasserman plots. As at the first glance, it may be difficult to interpret, but as time goes and when you look at more and more graphs, things fall into place. So while the patient is exercising, these graphs give the real-time depiction. So you can see from every when the patient exercises, this changes, this gets updated. So you have the left top graph, the left side top one is the ventilation and the load. So the ventilation increases as the patient exercises, And then next to that, on the middle top, you have the heart rate and the O2 pulse. So the heart rate is the pink line that is nicely increasing with exercise. But if the patient is on a beta blocker, the heart rate will not rise. Or if the patient develops any heart blocks or arrhythmias, so you will see whether the heart rate is flattening or not rising. Or if someone has a steep rise in heart rate, it can indicate either deconditioning or there may be autonomic dysfunction. Heart rate drop also you have to observe, because there can be changes in autonomic dysfunction. And then the blue line that is right below it is the O2 pulse. O2 pulse is a surrogate marker for your cardiac function. So you have to see whether there is a gradual increase of the O2 pulse. But if there is a flattening of the O2 pulse during exercise, that would indicate that the cardiac function is compromised during exercise. So you have to watch for all that when you are exercising. So in a young person, it can be multiple valvular disease, or it can be cardiomyopathy. In elderly people, we have to watch out for ischemic cardiac diseases, which can, even though the echo can be normal, when you're stressing a patient with this exercise, the O2 pulse can indicate that there is a limitation or a cardiac limitation. Then the other graphs, well, I'm not going to confuse you with a lot of medical jargon. So the other graphs are the VO2, that is your oxygen consumption, your carbon dioxide exhalation, which will tell you, which will have normal parameters. So they will have normal patterns. So out of this, if you look at the left side, your left side, the middle graph has the So this graph, so that this is the ventilation efficiency, the VEV-CO2 curve, which in this patient you can see that it is nicely going in the reference area. However, if the ventilation, if there is any inadequate or inefficient ventilation, such as in a patient who is not having proper breathing, irregular breathing, or inefficient VQ mismatch or ventilation perfusion mismatch due to either pulmonary vascular disease or lung parenchymal issues, then this VEV-CO2 curve shifts to the left. So it gives an idea about the patient, whether the patient has a lot of dead space ventilation or if there is inadequate ventilation. So then we have the heart rate and the VCO2 curve. Again, these are the oxygen and carbon dioxide curves. They have different interpretation values. Now this one is your breathing frequency and the tidal volume. So the yellow dots are the breathing frequency and the brown dots are the tidal volume. So when you start exercising, your tidal volume starts to increase to such an extent, and then it starts flattening out, but the breathing frequency takes over and the breathing frequency increases. This is also another important graph called the RER, the respiratory exchange ratio. Now, when we inhale and exhale, initially the RER, the respiratory exchange ratio, or the that is also the VCO, the carbon dioxide exhalation, VCO2 divided by VO2 should be less than 1. Now, when we start exercising, we exhale a lot of carbon dioxide, and when we exhale a lot of carbon dioxide, if you are hyperventilating, this even in the beginning, the RER value can be more than 1, but in a person who is at rest, it will be the RER will be less than 1. I hope you're with me. The VCO2 VO2 ratio, and then when we start exercising, our body's the oxygen capacity in the mitochondria starts weaning off, and the aerobic metabolism starts shifting to the anaerobic metabolism, and then you start generating bicarbonate, which dissociates into carbon dioxide. So there is a point where your exhalation contains more carbon dioxide during when you're reaching the peak exercise. Then the RER starts to go more than 1. So he is now here, you can see now the RER is reaching 1, and that is where the aerobic metabolism is shifting to the anaerobic metabolism. So again, not only this graph, but these two graphs also gives us gives the places where these lines are crossing, where the anaerobic threshold is now reaching. This anaerobic threshold is very important. It is an important measure which tells us our physiological limitation. I mean, there's one more slide on anaerobic threshold. It is important also for pre-op assessment as well, I'll tell you. So this is, actually, this is a more clear graph. So you have this graph in place, and at the end, so this you look at during your CPET exercise, and you have a lot of data at the end of the test. So you have pages and pages of data where you have to do some calculations, and also you have to give some values. So let's look at some basic values here. So here you have the spirometry in the beginning. So you can see that the FVC is 85% predicted, FV1 is 93% predicted. It's okay even if it's low, see, I'll tell you. So here in the so you have the cardiovascular response, the ventilatory response, the gas exchange response, and you have to pick up some important data. Out of all this, so you have the VO2 peak. I think if you if you're doing athletics, or if you have someone who does athletics, you would have heard about the term VO2 max or the VO2 peak. There are athletes who want to know their VO2 max, or whether they have achieved it, or how much more they can improve themselves so that their sports performance will go up. So this VO2 peak is the most important parameter out of all this data. And after that, then we start interpreting the other data. And just for interest, I will show you. So in this patient, the VO2 is 124% predicted. So this is an athlete. Now, normal person will have a normal non-athlete we take the cutoff as 80%. So if one of you who's a non-athlete does the CPET and gets a VO2 of 80%, then that is normal. And if the VO2 peak is less than 80%, then we have to start looking for some abnormality. Generally, when the VO2 peak is more than 80%, then it is unlikely that there is a significant cardiovascular or respiratory or metabolic issue, or something serious is going on. If there is, it will be a very mild condition. So in athletes, it will be usually about 100%. That is, they reach their VO2 max. And national level athletes, like the cricketers and national and international players, they go beyond 100%. Now, when you look at this graph, and when you have all this data, before you start interpreting the data, first you have to ask whether the patient did a maximal test. Did he perform to the maximum? Why did the patient stop? So you have to record that, and also note. So we give a patient the Borg scale, the phases where they can determine to what extent they felt the difficulty in breathing or the leg pain. So in our patients, we give the Borg scale. We ask them at the beginning of the test, how is your breathlessness before you start the test? So they will say somewhere around 1, 2. And at the end of the test, when they are really struggling to go on, you ask, where are you now? So ideally, it has to be 8 or 9, where they have reached the maximum intensity of the exercise. So our patients, I think sometimes they say, even if they are struggling to breathe, 5 or 6, but so in our setup, this Borg scale is a little, I don't know why they don't actually say what they feel, I think. So, but you can see, so ideally you have to go up to about 8. So you have to note why they stopped. Was it the leg pain? Was it the breathlessness? Did you stop the test because you saw some changes in the ECG? Did the blood pressure start going down? Or was it arthritis type of pain? Did they have knee pain? Was that why the patient stopped the test? So all that will be important to interpret your results. So to say that the patient did a maximum test, then you have to see whether the patient did 80% of the predicted workload. So for the patient's height, weight, age, and sex, the CPET calculates the patient's expected workload and gives you a value. Out of that, the patient should have done at least 80% of the workload for you to term this as a maximal test and interpret the data. the patient should, the person, we won't say patient because they are not, sometimes not patients. So the person will have to reach at least 80% of the maximum heart rate. So you can calculate your maximum heart rate by 220 minus your age. So that is your maximum heart rate that you will achieve. So when you're exercising, if you're going beyond that, you will have to do an ECG and see whether you're developing an arrhythmia. So then RER value, the respiratory exchange ratio that I mentioned, should be more than 1.15. So you have to, before you start interpreting the data and looking for pathologies, you have to look at whether the patient had a maximum test or not. And also we always check whether the patient reached the anaerobic threshold, which I showed you before, because if the patient did not reach the anaerobic threshold, it is very difficult to calculate certain values and give predictions. So this as I discussed before, the maximum VO2. The VO2 max is the maximum oxygen uptake, that is the predicted value for the patient. And so that is the 100% value. So if the person reached a VO2 of, let's say, 85% predicted, then we call it the VO2 peak. That is the patient's peak VO2. So he has not reached the VO2 max, but his VO2 peak is 85% predicted. So as it is more than 80%, it is normal. Now, if the patient's VO2 peak is less than 80%, there can be several reasons. One is the patient stopped the exercise before the maximum physiological capacity was reached, such as didn't try hard enough, or the pain was due to so when we are doing CPETs, the CPET room is very loud. It's like a cheering room. It's like a sports meet, because you're encouraging the patient, keep going. There's nothing wrong, because the patient is worried. They are coming to analyze their symptoms, and they are getting chest pain, breathlessness. They have a mask on their face. It's an unusual environment, and you have ECGs beeping. But you have to say your parameters are all right, your oxygen is all right. Keep going. Don't stop. And you have to. So the physiotherapist is encouraging and shouting. The doctor is giving encouragement. So then you get the patient to do a peak exercise test. So so it has to be an environment conducive for the patient to exercise freely and not have people walking in and out of the room. So it has to be a covered area, just like another lung function test. So maybe the VO2 was stopped low because the patient had deconditioning or unfit, not exercise for a long time. Or it can be due to a cardiac condition. It can be due to reduction in cardiac output, low oxygen extraction, shunt. It can be due to lung disease. So when there is low VO2 of less than 80%, it can be either the patient didn't exercise enough, the patient may be unfit or deconditioned. There may be an underlying cardiac cause, there may be a respiratory cause. So when you have VO2, then you have to start doing your detective work to tease out what is the problem by looking at the other data and the graphs. Now, as I mentioned before, the anaerobic threshold, so we have these three graphs. So you can see that here you have, there's a deflection point, or the angle starts becoming steep. So that is where the anaerobic threshold steps in. Here you have the VO2, VCO2 curves crossing each other. That is where the anaerobic threshold steps in. That is where the bicarbonate, there's increased lactate production, dissociation into bicarbonate, excessive carbon dioxide production, where the metabolic acidosis sets in. So this anaerobic threshold is important. Now, anaerobic threshold normally should be more than 40%. That means your anaerobic threshold should be more than 40% predicted. So someone who has not exercised for a long time, or who has cardiac or respiratory disease, the anaerobic threshold will be can be low. So it can be if it is like 30%, then that is very low. So then that means the patient's endurance, the exercise capacity is very low, and they can become fatigued. So when this anaerobic threshold is important for perioperative or post-operative risk prediction as well. We don't have the proper guidelines to give us the exact values, but in certain major surgeries like the hepatobiliary surgeries, colorectal, or mostly thoracic surgeries, when the anaerobic threshold is less than 10 in certain, so these values are derived from Caucasian populations. For certain surgeries, they mention and as an anaerobic threshold of 11 milliliters per minute, and for certain surgeries it is 9. So if we keep an average value of 10, if it is less than 10, it would indicate that the patient has a greater risk of perioperative or post-operative complications and will need prehabilitation before they go for major surgeries. So now you don't have to do CPET for all of these patients, but usually what we as respiratory physicians, we get referrals of patients with restrictive lung diseases, where if it is obstructive airway disease, we have to optimize the bronchial asthma. But if it is restriction, and let's say that if we see the forced volume vital capacity somewhere like 60%, and we don't, how do we give the risk prediction? So in those cases, only when we are not sure, when we can't give a proper risk prediction, then we can do the CPET and see what is where it is going wrong and where should we improve the patient. And sometimes, very surprisingly, people who appear frail, they are able to do the CPET. They pass this criteria, and your doubts are objectively cleared. Yeah, so this is what I discussed. Then we move on to the heart rate response. So you look at the heart rate, and so the heart rate has to linearly increase. This pink line, it has to linearly increase. So if there is any problem in the cardiac, such as ischemic heart disease, autonomic dysfunction, where there can be steep heart rate rise, and so the heart rate also has to drop fast. There is a rate, there's a 15 beats per 60 seconds. It has to drop fast. If it is not dropping fast at the end of exercise, or there's a slow drop, then that will indicate microvascular ischemia. Again, will predict a cardiac event, even if the other resting parameters such as 2D echoes are normal. So it will indicate autonomic or microvascular ischemias depending on the heart rate response and the recovery response. The O2 pulse, as I told you, it is the surrogate for the heart function. So if the O2 pulse doesn't rise to the normal value during exercise, that will indicate that either in a multiple valvular disease or an ischemic or cardiomyopathy, that is not allowing the heart to pump, or sometimes if the patient is on a beta blocker, also you will have the blunted response. Now, when you are doing the CPET, you have to keep an eye on the ECG, and ECG. So you have to look for ST depressions and other ischemic changes. If the patient develops 2 millimeter depression, that's all right. But more than 2 millimeter ST depressions with angina symptoms, you have to stop. But you can, if it is without symptoms, then you can go up to 4 millimeters ST depressions. Usually there is no ventilatory limitation. You have a lot of lung capacity, because not like the heart, there's two lungs. So it's very unlikely that a patient reaches the ventilatory limitation. If the patient starts reaching the ventilation VE max, then that means definitely there is something wrong with the lungs. Then you have this is the tidal volume graph. So you have the breathing frequency. It is nicely increasing with exercise. And you can see here, our tidal volume increases at the beginning of the exercise and then starts to plateau down. And after a certain amount of exercise, it will be the breathing frequency that will take over and keep up the minute ventilation. So let's move to our case. The case that we described, where she had lots of symptoms, all investigations so far negative. So we got her onto the CPET. Well, this is not her, but this is somebody else. But we did the cardiopulmonary exercise test. And if you look at the graphs, so here you can see the RER is very erratic, where even at rest, the RER is more than 1. You can see scattered breathing frequency and scattered tidal volumes. the ventilation curve has shifted a little to the left. So when we look at the tidal volume tracings, it is very erratic. So these are some examples from erratic tidal volume tracings. I will show you so you can see now, usually the tidal volume is nice sinusoidal pattern, but in patients with breathing pattern disorders, they are very erratic. So here is this. So you can see that in this patient, there is a lot of breath holding, there is erratic breathing. So here, this patient has what we call dysfunctional breathing or breathing pattern disorders. There are 5 types, and most of the time these patients are called, they are called they're labeled as something wrong in their head, but these are actual disorders which have to be properly identified and treated. So so what the importance of it is, you have an objective assessment to diagnose. So let's quickly move on to case number 2, a 52, this is the last case, 50-year-old male, previously healthy, smoking 1 to 2 cigarettes per day and complaining of difficulty in breathing on exertion for 1 year. First noticed when the patient was increasing the exercise during his gym sessions. Vocal cord chest tightness, vocal cord their throat constriction, and he also had a lot of investigations, piles of investigations, which were normal. So he underwent CPET, so his CPET was basically all right. But what we saw during the exercise was that the spirometry, so we do serial flow volume loops. That is, the patient has his lung function tested during the exercise, serially during the exercise. So those who are familiar with spirometry, you can see in his baseline graph is nice exhalation and inspiration. And when he is exercising, you can see a kink in the inspiratory curve. So we see that time to time in patients who have difficulty in breathing, throat constriction, intractable cough, gobble sensation, so they can have vocal cord dysfunction. This is a classic pattern of biphasic kink during inspirations. So it's called a trapezoid biphasic inspiratory curve suggestive of vocal cord dysfunction. The newer term is the inducible laryngeal obstruction. So you know when you have your vocal cords adapt when you inhale, but if they are so when in these patients the vocal cords come together when they inhale, so it's a paradoxical movement, can be precipitated by reflux, postnasal drips, even stress, and seen in asthma patients as well. Sometimes mislabeled as wheezing or asthma, sometimes managed as stridor, because they can come with harsh upper airway breathing. So CPET has its various roles in diagnosing and teasing out. So as I mentioned before, the CPET has a place in assessment, because now when you want to rehabilitate or prehabilitate a patient, you are handing a patient over to a physiotherapist who has to take the patient through a lot of exercise. So he has to be sure whether it is safe to take the patient through all that exercise. So once you have done the CPET and you know the saturation is not dropping, there are no arrhythmias during exercise, you can safely hand over the patient to the physiotherapist to do the prehabilitation for a good 2 to 3 weeks, working up to major surgery. So in summary, the CPET pointers to the presence of heart disease will include low VO2, rapid rise in heart rate, low O2 pulse or flattening of the O2 pulse, low anaerobic threshold, and so there will not be any ventilatory limitation, absence of ventilatory limitation. Pointers to the presence of lung disease will be low VO2 max. Exercise there is no cardiac limitation, so there is no heart, so exercise is not limited by the cardiac output. The O2 pulse will be normal. Ventilation can be limited, and there can be inefficient ventilation where the VE-VCO2 ratio is high. The tidal volume will not rise adequately, and there can be erratic changes in the RER tracing and the tidal volume as well. And in cases where there is lung parenchymal involvement, like interstitial lung diseases, there will be, and pulmonary vascular diseases, there can be desaturation. So, so in this brief talk, I have what I've tried to do is to give you an overview of the CPET, go through the indications and give you a kind of a glimpse of the what are the indications and what we can do with it. And of course, there is a lot more needed to go through and learn about it to interpret. So if there are questions, I'll be happy to answer to the best of my knowledge. And thank you very much.
So my task is to talk about non-invasive ventilation until the slides come up. Can I know how many of you all have been using non-invasive ventilation in your wards? Right, so almost everybody, right? So it will be very easy for me to, because I was saying that I don't have a lot of pictures in here today. But so anyway, we'll be able to talk about the current update. So what I want you all to know, right? So my aim today is to let you all know how to start NIV. We'll talk about acute and chronic separately. Start with acute and how to do it correctly, how to write a simple disease-specific non-NIV prescription, and to identify the early predictors of NIV failure and know when to escalate, right? And a little bit about home NIV as well, because some of our patients whom we treat with acute NIV would need home NIV once they are going home. To touch on the basics, right, everybody knows that there is two types of respiratory failure. We call the hypoxic respiratory failure and the hypercapnic respiratory failure. So in hypoxic respiratory failure also there is a place for non-invasive ventilation, especially the CPAP treatment. And here the problem is VQ mismatch. There can be initial hypoventilation can result in hypoxemia. There is a limitation in diffusion. There can be shunts and there can be a reduced inspiratory oxygen fraction as well. And type 2 respiratory or the hypercapnic respiratory failure, it is usually always a pump failure, right? So there will be hypercapnia in addition to hypoxemia. Now, selecting the right patient is very important. And when we are talking about acute respiratory failure, there are two types. Either it's just simple acute respiratory failure, hypercapnic respiratory failure, or it can be acute on chronic hypercapnic respiratory failure. So the cutoff values are given here. All of you would be familiar with. So you do an arterial blood gas, the ABG, which shows a PaO2 of less than 60 millimeters. We talk it's millimeters mercury, so less than 60 millimeters of mercury, with a carbon dioxide level more than 50 millimeters mercury. And the cutoff values, that is usually what we use for COPD, but in neuromuscular, OSA, OHS patients or chest wall deformity patients, the cutoff value for carbon dioxide is a little bit lower. And when it comes to chronic hypercapnic respiratory failure, the acidosis, there may not be acidosis seen because it could be compensated chronic respiratory, hypercapnic respiratory failure. And if the patient is having acute on chronic, then you will see a pH less than 7.35. Okay, so acute and right. So when are we going to start the acute NIV? So let me start with your nighttime casualty or your ward work. The patient comes, right? Very commonly a normal non-COPD patient comes with difficulty in breathing, very exhausted, very tachypnic, and using accessory muscles. So you would initially put them on controlled oxygen, and then you would start your usual bronchodilators, steroids, antibiotics if indicated. And then you should repeat do your blood gas value. So usually the guidelines recommend for you to give a medical management for 1 hour and then you do your blood gas value. And on that blood gas only, we decide whether the patient needs non-invasive ventilation or not. So if the patient has acute hypercapnic respiratory failure with persistent hypercapnic acidosis, despite optimal medical therapy, we do give them NIV. And if the hypercapnia is seen in restrictive disorders, such as neuromuscular or chest wall disorders also, even if they have less acidosis and they have ventilatory failure, then there is a place for non-invasive ventilator. ventilation. And work of breathing could be very high in these patients, and we would consider whether they are able to protect their airways and whether they have a lot of secretion burden as well, right? And we should provide very close monitoring for these patients. And you do not start NIV if you think that this patient is needing immediate intubation or is at impending respiratory arrest, unable to protect their airway, or they are very uncontrolled, agitated patient. And if they are hemodynamically not stable, if they have uncontrolled arrhythmias, then we might not consider starting on NIV. And when we talk about GCS, if very low GCS, usually 8 is the cutoff. If it is less than 8, we do not put them on NIV unless that low GCS is due to carbon dioxide retention. Then we can try NIV on our patient. Right? Okay, right. So according to the British Thoracic Society recommendation, if you treat 10 patients, right, you can see about a 50%, more than 50% mortality benefit in this hypercapnic respiratory failure group. So it is very promising, and it's a treatment modality which has a lot of evidence. So the main patient groups for NIV are COPD, acute on chronic, overlap with sleep disordered breathing. COPD overlap is very common, and neuromuscular diseases, chest wall, and in non-hypercapnic respiratory failure, in acute cardiogenic pulmonary edema, there is a place for continuous positive airway pressure treatment or CPAP treatment. So this is blood gas cutoff values is here. Acidosis should be there. There should be a carbon dioxide of more than 50 or 55. And your oxygen level could be less than 60 as well. But be very careful when you are putting a patient on NIV, there should be no contraindications. So you should know the list of contraindications, and always make sure you exclude a pneumothorax, because our patients with respiratory conditions, right, we know if it is a non-infective exacerbation, we need to consider certain diagnoses such as underlying pneumothorax, myocardial infarction, and arrhythmia, right? So we need to look at all of that also, but arrhythmia MI is not the case, but you should exclude a pneumothorax, because if there is a pneumothorax and you put on NIV, which is undrained pneumothorax, it can worsen. So we need to exclude a pneumothorax, and also treat reversible causes, optimize medical therapy, right? Okay. Now, once we decided, now we have done the blood gas, okay, our patient needs NIV. Then we need to decide, depending on the severity of this patient's respiratory symptoms, where are we going to place our patient? Are we going to keep the patient in the general ward? Are we putting the patient in a HDU setup? Or are we putting the patient in an ICU? So that is very important. So these are very evidence-based guidelines are there. So you look at the physiological parameters, I would say, your respiratory rate, right? And if it is in restrictive and obstructive disorders, the cutoff values are different. And if the patient is not the respiratory rate is less than 30, less than 25, then your patient is safe to be in a ward. But if it is higher, it should go to a HDU or ICU setup. Also, your GCS is being checked, and also we can look at the oxygenation also, right? And you can do the PaO2 to FiO2 ratio if you do arterial blood gas, and also decide how severe is your patient's condition. Then the patient needs monitoring. To what level? Your nurses, you'll have to advise them, okay, you need to monitor this patient. So at what level are we going to monitor the patient? Also, you need to give them clear instructions. So just use this as a guide to tell, okay, this patient needs very frequent monitoring every 2 to 4 hours, or whether the patient needs a continuous or very close monitoring in a ICU HDU setup. Right. Okay, so this is all what I told in a nutshell, but it's a very crowded slide. I apologize for that, because I like to have all in one thing, but I see it clearly, but unfortunately the people in the back will not see it. Right, so the indications I told you, COPD, you should know the blood gas cutoff values. In neuromuscular diseases, sorry, my cursor is not there, let me get the pen. But okay, yeah. So in neuromuscular diseases, in obesity, hypoventilation syndrome, we do give NIV. As I told you, look for the contraindications. There are absolute contraindications if your patient, because we know it's a mask interface, right? If your patient has a facial problem, a facial burn also, you can't apply NIV. So you have to look for the absolute contraindications, then look at the relative contraindications, or also look whether your patient has an indication to go to have an ICU referral as well, right? So when you're talking about NIV setup, so you will have to select the appropriate mask interface, right? So you know your respiratory patient is always a mouth breather in the acute setting, right? So your hospital patients, you see, would be always breathing from their mouth. So in the acute setting, we always do recommend a full face mask. Full face, we call it only in Sri Lanka. Full face in the other countries is the mask which goes all around your face. But it's the oronasal mask which we are calling full face in Sri Lanka. So oronasal mask for the acute setting in the patients who are receiving NIV should be selected. In the chronic setting or the home setting, it's a bit different, right? Okay. And then the initial pressures, those days we had one whole setup for all of the patients, but now we are going to more personalized care. So there will be, depending on the pathology, depending on the physiology, in the abnormality in the physiology, we will give different starting values. I'll talk about it in the next slide. And then you need to monitor your patient. You need to set a oxygen cutoff value. This is the range. So if it is a hypercapnic respiratory failure patient, it's usually 88 to 92 is your oxygen target, right? So you don't want above 94. But if it is a patient who is not an acute on chronic hypercapnic failure, then you can go 94, but never 100%. Because once it's 100%, you don't know whether you are giving too much oxygen or not, and oxygen is a drug. So we'll have to be very careful of the amount of oxygen we are going to give your patient, right? And also this part is very important. NIV is not indicated in asthma and pneumonia. You should know in your ward setup, do not give NIV for asthma or pneumonia patients, and keep them on. Suppose your patient is very critically ill and work of breathing is very high, and you are waiting for the ICU team to come and take your patient over. Of course, yes, you can put the patient on NIV until you transfer the patient to the ICU carefully, but not as a treatment modality just for NIV. So because I told, okay, don't give NIV for asthma and pneumonia, I cannot give. This is not the case. It's all your clinical judgment. Don't put them on NIV and keep them in your ward, right? They need very close monitoring. So in an HDU ICU setup, yes, we do try NIV sometimes initially for a very few, maybe 1 hour or 2 hours, to see whether that patient will improve, because we are taking some of the work of breathing out of the patient. But then at a ward setup, as a junior doctor, as a doctor starting on NIV, I would recommend do not try to attempt doing that first. First, you master your NIV skills, then you think about bridging another patient. Okay, so this is our personalized acute NIV prescription. So in COPD patients, right, we don't need a lot of EPAP. So EPAP, you know, is the pressure, the lower expiratory positive airway pressure. So that value, we don't need a higher value to open up your alveoli. So a lower value is enough. Usually we start at 4 or 5 is what is recommended. So IPAP about 12 or 16, and what is the science behind it is you need a minimum of 6 centimeters of water of the pressure support, right? Pressure support is IPAP minus EPAP is your pressure support to ventilate your lungs properly. So don't go below 6 of a pressure support. So that would be your minimum. So 12 and a 4, 12 and a 5, or even you can start 4 and a 10 is even fine, right? If your patient is struggling on it. And always you quickly increase to maintain the tidal volume, usual tidal volume. In your machine, you get the VT. VT is your tidal volume. 6 to 8 milliliters per kilogram should be there. And in neuromuscular patients, you don't need very high IPAPs, right? And you don't need very high pressures also here. So the minimum 6 is more than enough in a neuromuscular patient because they have nothing wrong in their lung parenchyma. It is the problem with their ventilatory pump failure, right? So a minimum pressure support is needed for neuromuscular. And when it comes to obesity hyperventilation or OSA COPD overlap, because we need a higher CPAP pressure or P pressure to open the airways, we start with the EPAP of around 6 or 7. Right, so that is the usual EPAP level to open the airways in the obesity. So if your patient is obese but COPD, so then you don't go for 4 to 5 of the EPAP, it will be a 6 or a 7 EPAP. So it's personalized, patient to patient, you can decide on the initiation of it, right? And also, if you're and you'll have to monitor the physiological parameters of the patient. Remember, you need to repeat your blood gas and check whether your treatment is working or is it not working. So we talk about we could talk about golden hours. So NIV also has a golden hour, the first hour after initiating NIV. We would see whether the parameters are improving or not. We look at the carbon dioxide improvement, we look at the pH improvement, we look at the patient's physiology improvement, that is the respiratory rate, the work of breathing, and also your peripheral oxygen saturation can be used here. Right. So this is a summary of the golden 1 hour, what we are supposed to do. First, look at the marks fit, leak, check whether the patient is comfortable. The mask should not be too tight because they can give bridge of the nose damage. So the mask should not be too tight. It should not be too loose so that it might leak a lot of airway. So the recommended leak is roughly about 25 liters per minute flow, but it should be less than that, right? Not more than that, because when it is above 30, the leak goes above 30, then the ventilation or the oxygen delivery and the carbon dioxide push out is not going to work properly. So that's why we need to make very sure that the parameters are okay. It's not that you put the patient on NIV and say, okay, now we have done our maximum for you and you improve on your own. It is not the case, right? Okay, all right. Then every 10 to 30 minutes, right, you can assess your patient initially, and I told you within minutes you increase your IPAP by 2s. Usually IPAP we increase it by 2s and EPAP we increase it by 1s, and usually we never go above a single number for EPAP. That is our usual values. This is all ward based and HDU based, not the ICU setup, right? In the ICU, they use different values. They go even beyond, and that is perfectly fine, right? Because the patients are continuously monitored. Why I say that is because, you know, when your EPAP is increased, there is a lot of pressure inside your thorax, right? So when the EPAP is too much, what happens? The pressure inside the thorax is too much. What is the thing which is not coming inside the thoracic cavity? What is reducing? Venous return is reducing, yes, right? So your blood pressure can reduce. So you need to make sure you do not do that as well. So the patient's blood pressure is something very much important thing. And you repeat your blood gas after 1 hour. right? You start NIV 1 hour, you repeat your blood gas, you change your parameters. So after 1 hour, you repeat your blood gas. So after 1 hour, you repeat it and see whether the patient is improving or not. So within 2 to 4 hours, if the patient is not in the correct direction, not proper, then you need to know what are we going to do. Is this patient for ICU care? Is this patient for invasive mechanical ventilation? If not, what is our level of ceiling? Are we going to keep the patient in the ward on NIV or not? So that all the decisions needs to be made before you leave your ward as a responsible registrar. Okay. Or you need to know that your junior colleague who is going to look after the patient over the night is clearly instructed what to do if your patient is not improving on your non-invasive ventilation. Right. So predictors of NIV failure, 3 factors. One is the patient factor, the ventilator factor, and the physiology factors, right? So you need to monitor your physiologic factors, your respiratory rate, your pH, your blood gas, your hypoxemia, right? You all monitor all of that and see whether it is improving or not. And also you can find out whether the patient is condition is deteriorating or not. Looking at the ventilator, if you are there is a very large leak, the fit is poor, right? If your pressures are not enough, right? There is something called ventilator patient asynchrony, which I'm not going to touch on because I can talk on that for maybe hours or so, but we will do it separately. Probably we might do another workshop from the college during this week in May, June or so. So I invite all of you, if you all are interested in this patient ventilator asynchrony and optimization of these things, this NIV treatment, you all are welcome to come. Right. Okay. Then sometimes the patient has poor mass tolerance. They will be agitated. They will have a lot of secretions. Right. So those all the factors. Right. If they are a neuromuscular patient, their cough will be very weak. Right. So we need to consider all of those factors which will be predicting NIV failure early. Right. So when you are troubleshooting, first you look at your interface, look at leaks, then you look at the comfort, right? And the patient factors, whether the patient is anxiety or not. Then you look at the airway for secretion, suck out any secretions, right? Then you go and look at your settings. Are the settings appropriate, right? To reduce the work of breathing of your patient. Is the pressure support enough? Not enough. How much is the EPAP? Is it triggering well? Is it cycling well? Right? So all of this, and then there are waveforms in your ventilator depending on what type of ventilator you use. You can use all of that, right? And also then if the patient, you corrected all of that and patient is not improving, then it can be that the pathology is evolving. The patient's condition is getting worse. Then what else can we do to help our patient is something what you can think of, right? Okay, so make escalation decisions early, right? And have them documented so that the next colleague or the person who is looking after your patient can think about what to do if the NIV fails. Okay, so this is all about acute NIV. You treated, everything is fine, and now patient has improved, blood gas has improved, and are you going to send the patient home? Okay, you are fine. Now you are safe to go home. Most of the patients, yes, but there are some of the patients who are not, right? So who are they? So if the patient is having persistent hypercapnia after an acute exacerbation of COPD, we need to reassess them to see whether they would need home NIV. Now we give NIV to be used at home setup as well, right? OHS, obesity hypoventilation patient, most likely would, if they had an episode, they would need another home NIV prescription as well. So patients with neuromuscular diseases, we know when the first thing to fail is when the respiratory muscles are failing, the first abnormality is seen during sleep when all our muscles become lax. So that is a condition what we call nocturnal hypoventilation. To diagnose that, we need to do continuous carbon dioxide monitoring at night together with your sleep study. And then you can see that there would be a rise in your carbon dioxide level from baseline to the early morning value. Usually the difference of a 10 is suggestive of nocturnal hypoventilation. So if your patient is a neuromuscular disease patient with nocturnal hypoventilation, that patient would benefit from early initiation of non-invasive ventilation at night, and that will give a mortality benefit for those patients, right? It is not, once the daytime hypercapnia is set up, it will be a not a mortality benefit, but a symptomatic benefit only. So this, you need to catch your patient at nocturnal hypoventilation level. So all neuromuscular patient, I would recommend them to have a respiratory assessment so that we could identify the nocturnal hypoventilation group, initiate them on NIV early and give them a better quality of life and a longer life with good quality, right? And if your patient has had 2 admissions with acute hypercapnic respiratory failure, definitely they would need a home NIV assessment, right? So what you, as a doctor in the ward, when you are discharging your patient, please do write in your diagnosis card that this patient had acute exacerbation of COPD requiring NIV. Make sure you write down the baseline ABG value, the reasons for NIV, right? And then you check whether the patient has the risk of OSA as well, right? What is the patient's BMI? All of that needs to be documented, right? And you should educate them on the equipment, mask interface, and make sure that the mask is comfortable for them, because otherwise they will never accept home NIV if the mask is a very bad experience for them during the acute stay. So you need to make sure the mask is very comfortable. Everybody, all of us give attention towards the machine, but it's not the machine, it's the mask and the patient's the comfort is something what we should think more on, right? And also have a plan for repeat arterial blood gas. Usual recommendation 3 to 4 weeks after discharge. You get them down, do a blood gas. If it is still having type 2 respiratory failure, please refer to a respiratory physician to assess for non-invasive ventilation, right? So even in chronic NIV, the evidence is mostly towards COPD, but we do use it on other types of restrictive lung diseases as well as neuromuscular diseases, right? So 2 to 4 weeks after an acute exacerbation, if the carbon dioxide is still more than 53 millimeters mercury, then there is an indication for home NIV. And when we put patients on home NIV COPD, there is evidence that just starting NIV for the sake of starting NIV is not going to help your patient. It's not going to give a mortality benefit or a symptomatic benefit or keep them away from hospital. So high intensity, that means you aim for normalizing your carbon dioxide value in the long term, right? So that is not happening, you should not happen immediately. You can do it gradually, but you aim for a normalization of the carbon dioxide, right, level, right? So you can increase the patient's pressure support gradually, get them 3 to 4 every month, right? Get them down and do a blood gas, assess, and then increase your pressure support gradually, or your oxygenation. It depends on what your blood gas says, right? If your oxygenation is the problem, you will have to increase your PEEP or your EPAP, or you can entrain a bit of oxygen, right? If it is your carbon dioxide level, then we would increase the pressure support. Right? So in NIV in obesity hyperventilation syndrome, also we would need higher EPAP and IPAP pressures as well. We have patients even in the Sri Lanka. So in UK, the patients, some of them are on pressures, IPAP pressures of 30, 34, right? But in Sri Lanka also, we have patients, we don't need that much high, but I have a couple of patients who needed IPAP of close to 30, 28, 29, 30, right, for their condition, because depending on how obese they are, right? And if you cannot correct your oxygenation, there are very obese patients whose oxygenation will not just correct though you put on the NIV. So you might need to entrain a bit of oxygen. We can do it by a small oxygen connector, which is available in the market to buy, right? You don't need to put a nasal cannula and then the mask on top of it. There are devices which you can entrain oxygen to the device itself, or there is a small connector which you can fix and entrain oxygen. And having said that, there are new masks where they have places for the nasal cannula grooves as well, grooves for the nasal cannula. So there are things like that as well. If you can't find oxygen connector, of course, you can go for a mask, which is a little bit expensive. Okay, then when you talk about neuromuscular diseases, also it is the same things, but you know, we need very less pressure values, and you take a lot of time to explain the procedure and ensure the mask comfort and gradual titration of the pressure supports, right? And in NIV patients, don't forget that their cough is very weak, so you need to assess their cough efficiency as well, and bulbar functions as well in the patients with neuromuscular diseases. So these are all the recommendations which I have told you all previously, right? Doing a sleep study for your neuromuscular patient is very important to catch them up at the earliest places. So these deep desaturations, what you see in your sleep study, even though you don't have a TOSCA probe or carbon dioxide probe, would tell you that this could be so it's a massive desaturation and takes a long time to come back to its normal. So these biggest places of or episodes of hypoventilation as well. Right. So when you are talking about NIV failure rates, so this is chronic NIV failure rates are very high with this neuromuscular disease group. So we need to identify which group is, whether they are responding well or whether they are failing the NIV treatment what we have given, right? So the recommended usage is at least 6 hours a day. That would be the minimum, right? So for us to see a benefit, but throughout the sleep is what is recommended. Throughout the sleep time, you can use it. If you need, you can use it for a couple of hours during the daytime if they are awake, while they are awake as well. If your carbon dioxide washout is not very adequate, right? And now we are going to a lot of telemedicine, telemonitoring, right? So these patients can be monitored as home patients as well. Unfortunately, we still don't have the cloud base in Sri Lanka to monitor our patients, but you must be knowing your patients who are from overseas would tell you that, you know, we have this app in our phone and I can see all my data on my app, and also I share it with my physician as well. So that is the future in home non-invasive ventilation, right? So if you all remember these 5 things, to start early in the right setting with a written NIV prescription, appropriate oxygen level, and an escalation prescription, right? And treat NIV as a time critical treatment, not just the final therapy, right? And reassess the patient 10, 30, 60 minutes. You repeat the blood gas every hour. If you change or after initiation of your NIV, you look for the mask comfort, leak, secretions, the patient and ventilator synchrony, the machine and the patient synchrony. Look for features of NIV failure. If the acidosis is worsening, patient's distressful, and the airway is compromising, always escalate early. Do not delay an intubation for your patient because it can cost a life. So after discharge, you need to identify who needs NIV at home and who needs to be assessed after 3 to 4 weeks. Okay, that's all. With that messages, I stop. Thank you.
So my talk today is practical management, troubleshooting, and safe removal of IC tubes. Those days, when I did internship in Ragam, that time there was no ETUs or no PCUs, all the patients with stab injuries, everything coming straight to the ward. And I did my first chest drain insertion in the ward in Ragama. So nowadays, I don't do most junior doctors, they may not get a hand as very junior doctors because of this PCU and ETUs. There are no conflicts of interest, but I'll show some gadgets just for education purpose. No financial support again. And there are certain do's in chest drainage, and we should check for a real indication, and then should get consent and advice to the patient as to what will happen next few days, and then who to insert and what to gather and how to insert during the insertion, and where to insert and the site. And it should be a sterile procedure, it's a small operation, and then how to secure and analgesia. And then we need to what drain system of bottle and position of the bottle and monitoring, and then patient monitoring and tube position check, then timely referral when needed, and assess overall drainage, radiological changes and status to the patient before deciding next step to move or escalate further imaging or surgical options or any modifications or adjustments or a second tube or applying suctions, etc. And there are certain don'ts. We should clamp only when necessary, and we should not milk or strip the tube in. Previously, they used to do that. And don't ignore the red flag signs. And then don't forget check for swinging of the tube for functioning. And don't remove prematurely. And don't restrict the mobility of the patient whenever possible. And then don't ignore cautious removal of the tube and aftercare. And what are the indications and what are the alternatives for chest drain? And usual indications are for fluid and air collections. And we can do pleural aspiration, and probably we can put pigtail or intrapleural catheters for the thin drains. And then post-operatively, we may insert for cardiac and thoracic operations, and prophylactically in polytrauma patients. And for safe air travel sometimes, we may put prophylactic tubes, and certain operations like esophageectomies, even without pneumothorax or hemothorax, we may put tubes, anticipating complications. And for air, the other alternative is pleural vent. I'll show you. There's a small new gadget. And this is on the right side, you can see, on your left side, you can see the effusion. But on the X-ray on the right side is a patient who underwent pneumonectomy. In pneumonectomy, once the lung is removed, the fluid fills automatically. And when the patient comes with some other complaint to the OPD or your clinic, we should not, treat this as a pleural effusion. And there's a natural cause that space will be filled. So I can remember one of our staff patients' father was sent to Maharagama Hospital. For third chemotherapy, he was admitted. The OPD doctor cleverly identified this effusion and put a tube drain, and then patient got ascending infection and died. So we should always think after pneumonectomy, there's a space and it will fill up with fluid, and there's a slight shift of the mediastinum towards the operated side. And the one on the left, you can see this is not a pneumothorax, this is a bulla on the right of this, and we should not insert thinking it's a bulla, is a pneumothorax to the tube to the bulla, and it might end up in, if there is a big communication with the bronchial tree, it might end up in bronchopleural fistula and patient can worsen. And the one on the right is a tumor actually. The tumor, if you have a slight suspicion is not tally with normal effusion, always best at least to do an ultrasound scan before putting a tube. Otherwise, you'll be putting a tube right into the tumor, and patient might end up in disaster bleeding. And who to insert? I believe most competent patient or competent person in the unit should be put in the tube. We should not delegate it to the most junior doctor. And in fact, some of the difficult tubes I put myself, and I enjoy putting tubes because for the last 20 years I have been putting tubes as SR for 4 years and as consultant for the last 16 years. So and you get some satisfaction when you put a tube well and when it functions. So and patient also benefited. And if a most junior one or unexperienced one put a tube, it might complicate. Again, we will have to manage. So I personally put, if I am free, I will do the tube if it's necessary. And where to and when to be is either it could be urgent or late. If it's not very urgent in the middle of night, you should not ask your junior to put the tube if the patient can wait till next day morning. It's a saturation fine, patient not distressed. Better do in the morning hours when everybody is around without asking you on call, say, not very clever, somebody to put a tube. Like that's the principle now even in UK nowadays. They don't do appendicectomy if it's not ruptured in the middle of the night. Now, training time, appendicectomy should be done whenever diagnosed. Now it's not so. You can wait till next day morning. And where to, if it's a unilocular, usual safety triangle is fine. But if it's a locular one, we can do either ultrasound guidance. And if it fails again, we should go for a keyhole surgery. And all this, as I mentioned, it should be a sterile procedure. What to insert? So conventionally, we have tubes with or without trocars. So these are normal tubes without trocars, and there are tubes with trocars, like cannula stilet and I won't recommend stilet ones for the very junior ones until you have put at least 10 tubes. Don't use trocar tubes. And there was an incident about 2 decades ago in one down south hospital. They put straight to the heart and patient died. The trocar one is a very rigid one, and even if you use, I recommend to use you take your tube. Imagine this is a tube, and you should guard your tube with your non-dominant hand and insert, so that at least your fingers will rest on the skin and it will not. There are some seats here. If you can come, some medical. And the sizes may vary, and there are straight tubes as well as curved tubes. These are straight tubes, and for cardiac surgery and thoracic surgery, we may use curved tubes. Naturally, it's curved, like Ballagina is designed to be curved. And there are different sizes from 8 French to 40 French, but usually what we see are 24 to 32 in our setting. And for pediatric population, there are small ones as well. And there are nowadays the Seldinger kits also. You can do the same Seldinger technique that you use for central line insertion. And on the left side, you have some dilators, and we can insert. It's actually very easy. And nowadays, I think some of the respiratory units they have. In fact, ministry is going to purchase them. And the long-term pleural catheters are, I'll show you, is meant for prolonged pleural effusions, such as malignant effusions. And this is an intrapleural catheter that is for malignant disease and all. If you can see here, actually the actual insertion site to the chest and the skin exit site is 2 different places, and in between there's a small Teflon, this is white bit, and it is in the tunnel of the skin. So it's sealed. So the usual tubes, if you put, it can get infected after 2 weeks, the insertion site get macerated, then it can leak. So this will prevent, that leaks. So it's well sealed so that patient can keep the tube for about 3 months, 3 to 4 months. Those are silicone tubes as well, not normal tubes. And this is the pleural vent that I mentioned earlier. This is designed for pneumothorax. Again, there's a unidirectional valve somewhere. Here, unidirectional valve, and can be inserted under local anesthesia. And on the top, we can see whether there's a small diaphragm on the top. We can see from the top whether it's working or not. So this is how, in fact, this one I used in private sector on a Maldivian patient actually. And there was a gap in the apex after a lobectomy. And in fact, this patient resides in Sri Lanka. So far, couldn't fly back to Maldives, and their whole family is living in Colombo. And this one is removed now, long ago. It's really a good agent if you can't remove the tubes for, say, long-standing pleural air leaks. So this is a very good agent. So when this function taken over by this, we can remove the tubes. Unfortunately, it's out of stock these days. The company, they stopped it to production, but it will come up again according to the agent. And how to prepare the patient in the ward, need to educate and consent. always should indicate the probable duration. We won't be removing it a day or two. In private side, some of them are asking whether doctor that's the question they ask. So sometimes we may have to keep for weeks. So we won't be able to remove. And the limitation that they can't do certain movements, we have to take the bottle always with him. Those things we have to explain before. And need to shave the area just because of the plaster thing, and mark the site. You visualize your X-ray, other will be put in the tube in the front side. And fasting only if patient needs general anesthesia or sedation. You need to have all imaging ready, and clotting tests need to be done, especially if the patient is on antiplatelet or anticoagulants, or if the patient has liver disease. And need to send required bottles and tubes for theater or the procedure room. And what together again, all tubes, bottles, everything, local anesthesia, everything need to be ready. But just for the juniors and trainees, if you are in UK or some other developed country, if you are designed to put a tube, you need to gather everything, bits and pieces from all the cupboards. There are no attendants, luxury. You have to find everything. Lignocaine තියෙන සිස්ටර්ගේ යතුරු තියෙන සිස්ටර්ගේ සාක්කුවේ. ඒකෙන් lignocaine ගන්න ඕනේ as a control drug. So you we need to be ready with everything and before cutting making cut දැන් cut එක දාලා ඇඟිල්ල දාගෙන අපි ඔක්කොම අරයට මෑට් එක CR එක ගේන්න කියලා. You can't do all this. You need to know all necessary things are around. And should be a sterile instrument set and trolley, blade, mosquito, Robert's faucet, suture material, everything need to be there. And this is the conventional we call is a safety triangle. In fact, the definition now they have slightly changed. It's not the posterior axis line, it's a mid axis line, anterior axis line, and the fifth rib level. So in order to prevent big injuries, especially this is good for the most juniors and who are putting the tubes for the first time. Or else, if doing for a tube fluid location, we need to mark with ultrasound and we can put the tube in the marked site. And always is a best practice to aspirate the fish fluid before putting the tube so that you will see some fluid in the syringe. And anesthesia, if ventilated or paralyzed patients may not need, but if sedation needed, you may have to purge extra dose of local anesthetic. And pediatric age and very excited patient, you may need sedation or anesthesia. And need to give proper dose of local and infiltrate well and wait till it works. And most patients, it's a nightmare. If you remember the patient had the ICU, that is, if you ask 10 patients, 9 patients will tell that was a really bad experience. That is why, because we give local, but you don't wait because the operator also is in stress. And but you have to wait good 5 minutes until it works and infiltrate well. And what I do is, skin cut the parietal pore is very sensitive. You put your needle through the skin, through the wound, and infiltrate well into the intercostal space. Otherwise, it will be a nightmare actually. And you can always combine it with some sedation. You can give midazolam and some fentanyl also if your anesthetic is around. And then post procedure also ensure patient is pain-free, otherwise patient is not going to comply with physiotherapy or mobilization. And post-op pain, because when the anesthetic effect is gone, and he will not move a pilimac in the and that way. So we want patient mobilized. And procedure, as I said, sterile and size of the cut. Reasonable cut. And it's the blunt dissection usually after the skin cut. We usually either Robert's forceps or straight forceps. We go bit by bit. Always hold your gadget with the non-dominant hand and little by little, and don't do too much also. Somewhat overzeal a second. Skin then what will happen is the insertion at the rib level, the cut is very large. So that is you're asking for surgical emphysema and all. You should tube එක යන්න පුළුවන් ගානට retract කරාම ඇති මේක. Not too much. Robert forceps එක තමයි immediately දිගයි. So මේ මෙතනින් ගොඩක් මේවා කරනවා මෙහෙන් හොඳ ගොඩක් පළල වෙනවා. එහෙම වුණාම ඇතුලේ rib level එකේදී cut එක ගොඩක් ලොකු වෙනවා. ඊට පස්සේ tube එක පැත්තකින් තියලා ඊට වැඩි ලොකු ඉඩක් තියලා tube එක වටේට. That's what happened. අන්තිම ලෙඩා කහින වතාවට ඇතුලේ තියෙන හුලන් ටික ඔක්කොම ඇවිල්ලා subcut emphysema වල ලෙඩා මිචලින් බැබික් වෙනවා in no time. So those are practical tips which I have seen over the years. And always they say on that diaphragm, focus on the diaphragm, you make a cut and try to hit the space above, and you make a small sort of tunnel like. You try to hit then after tube removal, there will be a flap of tissue which acts as a valve. You go to close and make try and wood space. And always use your finger to release the additions. And direction of the tubing, actually those days we were told if its air should go to the top and fluid to bottom. If it is unilocular collection, if the holes are within the pleural cavity, that will do the job if the patient is mobilizing or good physiotherapy, the whatever content will drain. And anchoring, we will do good anchoring is required. And nowadays new surgeons and some physicians, they put elastoplaster body stripping whatever they put a plaster. But we have seen a lot of patients with tube falling out. We prefer to anchor with a good size stitch. We use usually #1 nylon or black silk. And how to confirm the position after the insertion, and clinically we can look for signs and symptoms. Patient will be relieved. And then visual evidence of bubbling and drainage and swinging. And there's a fog. As soon as you insert the tube, you can see in small fog coming inside the tube. If it's for pneumothorax, and if it's fluid or blood, you can see the blood or fluid. And radiologically, we should always confirm with chest X-ray or with ultrasound or II image intensifier. And always note the position of the sentinel. Sentinel hole tube hole. The last hole on the tube, somewhere here. So need to see the X-ray whether the hole is inside the pleural cavity. Sometimes we can see the hole is in the chest wall, especially obese patients. We may not achieve. And in obese patient, I personally prefer to put the trocard tubes. It's easy. If you angle it's a nightmare. Your fingertip will not reach the rib cage. So those patients, actually the trocard tube is a good tool, but need to be inserted very carefully. And if you can see on the left hand side, so usually we don't do lateral X-rays. You can see how tube kink. This is a post-op one. Actually, this was from last week, one of my operated patients. You see, when you do the lateral X-ray also, this is, end-on appearance. You see as a kink. X-ray taken this way, the tube is going posteriorly and in the paravertebral gutter. So there is the true lateral view of that X-ray. It's actually not kink. It's the end-on view here near the red dot. So especially the X-ray if the tube is swinging well, if it's draining well, but don't go and modify all the time. Leave it. If it's functioning, leave it. Even if one of the holes are in the chest wall, if there is no surgical emphysema, if the tube is working, don't meddle with it. Just leave it. Too much of alterations also will bring some complications. Stitches, plasters, securing, I mentioned you earlier. And what drain system? And there are certain bottles. This is a 2-compartment bottle. This is the most common one. We have 2 compartments, and the tube will go on this side, and there is a water level we can fill up, and then this plastic tubing will inside. There's a tubing. It will go straight to this side. And then there's a single compartment I'll show in the next picture. And there are 3 or 4 compartments for cardiac surgery. The more fancy bottle types are there. And there are bags also now, ambulatory bags and smaller bottles for intrapleural catheter, 40 bottles here. So those are for easy patient mobilization. And there's one called Helmich valve. I'll show you a picture later. That is without a bottle, there's an induction valve which can connect to the IC tube. And position of the bottle always important. We usually ask the patient to keep it below the waist level, or below if the patient is bedridden, below the chest level. And then keep open the vent of the bottle unless suction is applied. The vent is Ruwanthi Jayasekara මම ටියුබ් එකක් දැම්මම මෙන්න මේ ප්ලාස්ටික් පොඩි කැප් එකක් තියෙනවා මේ වෙන්ට් එක. වෙන්ට් එක කියන්නේ ඇතුළට වන්කොට ඇතුළට තියෙන හුලන් ඩිස්ප්ලේස් වෙන පොඩි මේකක්. එහෙම නැත්නම් අපි සක්ෂන් ඇප්ලයි කරනවා නම් මේ වෙන්ට් එකට දාන්න. I always make a put into the dustbin. Otherwise make a තියලා යවුවොත් එහෙම මේක ලෙඩු වහනවා මැස්සෝ වහනවා කියලා. And the other thing, even transferring people, sometimes patient transfer from Trincomalee to Velisera, they come with the capping and telling tube not functioning. The whole reason for this is, closing this. This is a closed system. Boruta Batella leda inna. You make it a closed system by cap. Putting this cap. Make a galada lead that. Because some of the bottle make a body gadget take make high class and both mana katlama. Make a theana got a ego comat. After hitro make a mahanda amataguna doctor again. So they might close it. Always take a couple of inkarana. That's a very good tip. Otherwise, a boruta batella. And there nowadays there are some air leak monitoring system. I'll show you some pictures. And the other one also I'll show you. Like this on the middle, I showed you that this is a good example. That cap is closed, right? And you can see the corrugated tube in there on the next one. White corrugated tube production other level. This has to be near this one to prevent kinking of the tube. I always during the board round I ask, you see, make the system of board round and calling. This is meant to be around this yellow cap. Make a meme. They don't have a fluid, but like a kink and a valakanda. You think at the Gilaband may hospital Kia corrugated tube, but is done for a purpose. Take a use current. And these are the types of bottle. On a bottle like a bottle like a single compartment. Sometimes that the tube in a design in the bottle itself. That's another mistake. The moment patient coughs, those are mistakes I have seen in real life situations. Right? Hurry tricky round bottle. Round bottle, right? It's very important. And the next one is a bag, which is for the Seldinger bottle types and the IPCs. And this is the Helmich valve. Last week with Mage Suddekiti after trauma, he was escorted and just a pneumothorax. And the insurance doctor came and removed the tube, put a clamp to the patient's side, and insert this also called flutter valve, or the Helmich valve. Patient air transport. This is unidirectional valve. But this is not good for fluid, but it's only for air. And these are the new fancy bottle types for monitoring air leaks. Actually, those are very useful. There's one in Velisera, but in private sector we hire these machines. Cost about 80,000 for the tubing system, and we can monitor. There's a screen there. We can monitor the actual air leak and the trend also. So it's a very good tool, and it can apply suction as well and monitor the air leak. You can see the numbers per minute, how much of air leak is there. You can monitor, and depending on that, we can make decisions. And slowly we come down on the suction, and eventually we can remove the tube. This one was again another foreigner actually using, he has a garment with jobs. He's a good German person, and he had a pneumothorax. He didn't want the, I inserted the tube in, he didn't, then Hamadama bubble, the only way I could convince him was we applied this gadget. And then with that also air leak present. And then eventually he was convinced that there is a continuous air leak. And he was taken to the theater. That's you can see the bubbles here. So, and post-op also be inserted, and he eventually now is back to work. So sometimes you can't concern, and you laptop page and pneumothorax. He is a master of pneumothorax. In 7 days, he Google everything, and then only way to convince him was to this. But hulan leak then he agreed for VATS and did the VATS, and we did a blebectomy on top and fluorectomy. You can see the bubble. That was the real life. The best picture of how it bubbled during the operation. This is another type of bottle, another component. And post-tension, what are the other things we need to do? We need to always give physiotherapy, and drain chart is very important. And with regard to volume and quality and the air leak. And patient air leak normal. And how frequently you should monitor or chart will depend on the time since insertion, type of the drainage, whether it's air, blood, or effusion, or chyle, and clinical condition of the patient, and then type of the procedure, whether it's thoracic or just a drainage, and volume of drainage, whether it's high output or sudden drop, trend, and then type of drain system, digital, real time monitoring of the just standard underwater seal, and we should mobilize whenever safe. And this is a common scene that you see on the left hand side. Some of the fluid may have gone to the other side, and we can clamp or we can bend the tube in, and always before measuring we need to put that into this side, otherwise your measurements are wrong. And on the left hand side you can see a lot of bubble, there's a huge air leak, so that air leak cannot make a that's a natural thing. Again, fluid your measurements are wrong. And this on the left, you can see, I told you the quality also matters. Now, this is a chylothorax patient who was there 2 weeks ago in our hospital. Can you cough a bit, please? Good cough. You should see the swing and the during the workouts. I think it's high time to change this computer also. And post insertion and decision to apply a low pressure suction and tube site dressing once in 2 to 3 days, and prophylactic antibiotics, and it will reduce the infection. And always check the connection and function, and especially after position change, and see the leak at the tube site, and with the patient neurosurgical emphysema, and frequency of change in the bottle will depend. Usually we ask 4 to 5 days. If it is purulent or pus, we may have to change it early. I'll stop. What time can I stop? I know your tea time we have passed. It's not me, because previous 2 speakers also took 10 minutes more. Do repeat imaging. Always confirm the expansion of the this one with the repeat imaging. And in case of blocked tube, what we'll do? These are actually practical tips. I will take 5 minutes to finish, right? So these are practical tips. No milking and stripping, advocated nowadays. You can flush it, and then you can remove the connector with the clamp on the patient side and flush it with the bladder syringe, and then reconnect and see whether it's working. And always encourage mobilization, spirometry, and breathing exercises. Tube migration or malposition, imaging to confirm, and may need adjustment on a new tube under guidance. And what we'll do if there's an accidental fall, and brisk application of local pressure as you noted, and then tightening the pursing suture if it is available, and either put occlusive dressing there, and arrange X-ray, chest X-ray. If the lung is collapsed compared to previous X-ray, might need another tube or surgical intervention. And always we recommend don't insert tube in the same track. But if it's within say 6 hours or so in practical setting, we might procedure room but don't use the same track, right? Then accidental disconnect another tube. Clamp the tube as soon as you note it. And if the tubing is on the bed or patient's own clothing, clean with some povidone iodine, and you can reconnect. And until the new tube set is ready. And may trim off if 1 inch of tubing. Because හැම වෙලේම අර connect එකට ගහනකොට මේ බටවලට මේක තිබ්බම මේ වගේ තර ප්‍රත්‍යක්ෂතාවය කියලා එකක් තියෙනවා. you know, if you මේ මෙතනටම ගහපුවා මේ බටේ ලොකු වෙනවා. ආපහු අපි මේ බටේ මෙතනට ගහුවොත් මේ you know it might leak. ඔය මේ ඇදලා බලුවොත් ටක් ගාලා ගලනවා. So what I will do is අපි එකවර කර ගැලෙමු. මේකෙන් හොඳ අලක් විතර කපලා අයින් කරලා fresh tube එක ගන්න. Those are small practical tips. මේකම ගහුවොත් මේක leak වෙනවා. එහෙම නැත්නම් අපි සමහරවිට මේ connect එකට පොඩි elastic pass කැල්ලක් දානවා. නමුත් ඒක මම ඉංග්‍රීසි වල වැඩ කරනකොට ඒගොල්ලෝ කැමති නැහැ මේකට කරනකොට ඒගොල්ලෝ කියනවා මේ ප්ලාස්ටරේ අගුන් හරි safety concern මේ ප්ලාස්ටරේ ඇතුලේ disconnect වෙලා තිබ්බොත් ඒක දකින්නේ නැහැ නේද. They don't like you know putting the plaster in the connector. මේ කියන්නේ ඒක ගහන්න එපා. වැටුනොත් වැටුණා වගේ then we do under the plaster it might have dislodged තිබ්බොත් අපි දකින්නේ නැහැ. There is a point in that also here. And repeat X-ray, and if the lung is down, may need low suction or enhance the physiotherapy. And fracture එකක් මුත් මොකද කරන්නේ? ඒ සතිත් මේ සිද්ධියක් වුණා අපේ ලේකේ. As soon as you notice, you have to put a clamp and inspect to the damaged side. And එතනින් කපලා දාලා ඉවරලා fresh side එක ගිහලා tube එකට දාන්න. ගොඩක් වෙලාවට එන්නේ tube එක. දැන් එන්නේ Indian ඒවා. ඇත්තටම very low quality. And one other thing to prevent is අපි clamp කරනකොට don't clamp across like this. So this will engage more pressure. You should clamp at an angle. හැමලෙම මේකට පොඩි stop එකක් තියෙනවා. පොඩි 4x4 gauge stop එකක් තියලා clamp at an angle. ඒකට ලොකු surface area එකක තමයි pressure එක යන්නේ. Whereas if you clamp you know at right angle, it will induce more pressure and high chance to damage the tubing. And දෙතුන් වතාවක් clamp කරන වෙලාවල use different side. Ask the nurses not to clamp the same side. මේක fracture එක. මේ medical පාවිච්චි කරන නෙමෙයි හදලා තියෙන්නේ. So they will get fracture. So those are small tips. And a segment දාලා unclamp කරන්න, but always do X-ray to confirm whether there is a new thorax. Leak at the tube side is a common again. මොකද කරන්නේ? ගොඩක් tube ගොඩාලා තිබ්බාම leak වෙනවා. leak එක සමහරට පේන්නේ නැත්තම් ගන්න බෙසින් එක ගලවලා බලන්න. බෙසින් එක ගලවලා betadine පොඩ්ඩක් apply කරලා ඉවරලා මේක පොඩ්ඩක් එහාට මෙහාට wiggle කරලා බලන්න. මම තිබ්බා betadine චුට්ටක් ගලවලා මොහොම කරලා patient කියන්න පොඩක් අහින්න කියලා. අස්සම් you can nicely see the air leak on the betadine. So you might need an extra pursing suture. If it's a long standing tube, may need resighting. අලුත් තැනක දාලා මේ tube එක ගලවන්න වෙයි. Long standing tube එක because always the skin get excoriated. And this is another thing that you note. The fluid column rises in the tube column. This happens with negative pressure. There are a few reasons why. And ඔකට කරන්න තියෙන එකම දේ කොච්චර milk කරත් මොන කරත් හරියන්නේ නැහැ. You put a clamp on the patient side and disconnect from the connector and raise the tube. And you know පටස් කරලා fluid එක යනවා bottle එකට ආපහු reconnect කරනවා. It's because of the negative pressure. සමහර block වුණාමත් වෙන්න පුළුවන්, but need to find a cause. These are the management options for long-standing tubes. Repeat imaging and consider adjustments and new tube insertions. And pleural disease if the lung is well expanded. And decide on operative management, liaise with thoracic team. And there's an option to send home with the tubes also if the patient is educated enough. If they have transport facility, private sector bottle in the van, sometimes we send the patients home. Surgical options to minimize tube bearing time. Exact procedure will depend on the original disease and prevailing status of the pleural cavity. These are the options available. And refer to thoracic team when in doubt and issue is not sorted and condition not settling or if the worsening clinically or radiologically. And pass history of thoracic or cardiac surgeon always contact and arrange additional imaging like repeat X-rays, scans or CT scan. And do preoperative echo and lung functions. And if diagnosis is not clear, always contact. When to refer to thoracic surgeon before tube, suspicious imaging. Or the predict post-insertion need for a thoracic input and history of previous cardiac or thoracic surgery. And when to refer early is unexpected bleeding, significant air leak, bubbling, or patient going into sepsis, or worsening of surgical emphysema, worsening hypoxia. And imaging shows localization of the fluid, poorly expanding lung despite low suction. And tube inside lung parenchyma. This is a common thing. Lung is but most of the time we remove with observation in the theater. But most of the time we don't have to do anything. But I think it should be done in a specialized center. And patient plan to fly in near future, or a station in a place where there is no medical facility. When to refer late, long standing tubes, unresolved pleural space or collapsed lung, prolonged airly, and if you are in doubt about the underlying lung process. And there are certain don'ts also, clamping, I said, only when necessary for the patient positioning. And don't ignore the red flag sign. Sudden stop. So you have to suspect whether it's a block. Then massive airly, continuous bubbling. And then sudden respiratory distress, subcutaneous emphysema, and tube disconnection or dislodgement, and sign of infection, tube site or the pleural fluid color, and cardiovascular instability. And don't forget check swinging trend. And don't remove prematurely also. And drain is no longer necessary. Lung expanded and the radiological resolution and drain criteria met as per unit protocol. Then bypass thoracic surgery usually our patients keep for about 100 ml. So there's no, you stick to the unit protocol and ongoing ARLE, clinical assessment and thorough digital drainage system method. And if it's a pneumothorax, we may clamp the tube for 12 or 24 hours and repeat X-ray and see whether the lung remain expanded. And if the patient is on suction, always better to keep him off suction and then repeat X-ray to see whether the lung stays the same. And don't restrict the mobility of the patient if stable. And in some units, even in NHSL this happens, you put a tube in and patient is restricted to the bed, and the next day patient, or in the same evening patient is catheterized, and the next day they start low molecular tapering also. Saying patient is immobilized. You make a good person a real patient. So these things we have seen in the National Hospital of Sri Lanka also, in Colombo. I don't know, I doubt whether it may not happen in Kandy, National Hospital. And educate before insertion and show how others do. Our hospital trolley, I'll show you in the picture. And that's a good way to mobilize. We have trolleys, design made trolleys for the patient can mobilize well. He walks around actually. It's very friendly trolley. I don't know whether these are available in Kandy. Arinda, you can, as a post-Congress thing, you can initiate one. I can find the contractors from Malaysia. And oh, that's great. And don't ignore the causes tube removal. Tube removal is also important. Patient but patient so it has to be done. Personally, I instruct my juniors to give some local anesthetic, clean, and it should be a sterile procedure. Offer local patient, make it within non but you choose. And clamping not essential actually. Clamp not essential. And the phase of respiration, whether it's in deep inspiration or deep expiration, you stick to that. But only in deep expiration, the next step is inspiration. Expire is still negative, especially bulky, muscular people, they might have still negative pressure. And when ready, tell the patient to hold the breath in deep pressure. This is just a trial. Halfway, book so always have a trial before removing. And if it's not principally Asubi and some but I keep my non-dominant hand here and ask the patient to face ask to put the then ask the assistant to hold the hand and then I tighten the piercing suture. You have to be a little tactful also. And then watch for immediate signs of pneumothorax discomfort. Always do X-ray and monitor the vital signs. And don't rush to remove the sutures also, especially after pneumothorax effusions. We have 7 to 10 days sutures galana, but effusion build up and it in a outer skin actual track is not healed well. Inside tikatosa medibrutian, nothing galivogamang Jugala Hulam Watropara Elitanama, so need to be always wait till good closure of the skin and subpart tissue. And follow up, we need to do serial X-rays and look for tube site complication like scars, tumor deposits. Malignant diffusion, we have seen tumor deposits there, pain, air leak, fistula, or sometimes missed stitches, and physiotherapy breathing exercise and evidence of persistent of the original disease, and may consider thoracoplasty with or without plastic surgical input. This is some take-home messages. Sorry for taking extra time, and thank you very much, and good luck for upcoming 48th your annual academic sessions are in there. Thank you for inviting. Thanks for patiently listening.